Hello, Namaste. I am Dr. Lok Raj Chaurasia and I am working at Kirtipur Hospital as an orthopedic hand and microsurgeon. So, coming to today's topic, we shall be discuss about all the orthopedic questions asked in our MEC for the year 2077. Please make a note, all these questions have been collected by our fellow students who have collected after giving the exams. So, coming to the first question. So, Allen's test, it is used to test. So, the options are A, B, C, and D. The ulnar nerve, radial nerve, median nerve, and check the patency of radial and ulnar artery in deep palmar arch. So, let us know the theory first. So, if you see this is the vascular anatomy of our hand. So, Allen's test is basically used for testing the patency of the nerve, of the vascular continuity of the radial and ulnar artery. So, if you see this is the ulnar artery, the radial artery, and this ulnar artery, it forms the superficial palmar arch as seen here, and the radial artery, it mostly contributes to the deep palmar arch. So, the superficial palmar arch is more distally situated and the deep palmar arch is more proximally and it lies underneath the muscle. So, other questions that can be associated with this or just a similar question is like the ulnar artery, it provides 80% of the blood supply to the hand, while the radial artery, it supplies only 20% of blood supply to the hand. So, since this is now coming to the options. So, if you see the options are mainly ulnar nerve, radial nerve, and median nerve. So, Allen test is basically a patency for testing the arteries. So, another confusing option that can be given is check patency of the radial and ulnar artery in deep palmar arch. So, it can be either superficial palmar arch or deep palmar arch. Coming to the second question. So, a 27 years old male complains of stiffness and back pain. He mentions that the symptoms increase on rest, decrease on movement. So, which serological marker do you send to reach the diagnosis? So, it's a young aged patient in 20 to 30 years of age. So, these patients usually they now see, if you see the symptoms, all these symptoms increase on rest and decrease on movement. So, the likely diagnosis is the ankylosing spondylitis where the symptoms increases on rest, or even the RA, even this even in case of rheumatoid arthritis, the symptoms increase on rest and decrease as we go on moving the joints. So, then the other diagnosis like the osteoarthritis, these improve on rest and they worsen on movement. So, we have two diagnoses left. One is rheumatoid arthritis and other is ankylosing spondylitis. So, coming to the options. So, if you see the question, they have complaint of stiffness and back pain. So, back pain, so it means the spondylitis, anything associated with spondylitis, back is the spondylitis. So, the patient has back pain, so ankylosing spondylitis is the most appropriate answer. In case of rheumatoid arthritis, usually the joints of the hands are involved. In case of ankylosing spondylitis, the central system is involved, usually the spine and the spinopelvic joint. So, now coming to the options. So, if you see the first option is antinuclear antibodies, rheumatoid factor, HLA-B27 and double-stranded DNA. So, rheumatoid factor, it is coming to the second option. So, the second option, the rheumatoid factor, it is a screening test for rheumatoid arthritis. It is not very sensitive, and it is not very specific even for rheumatoid arthritis. ANA and dsDNA, these are the tests specific for SLE and JIA. So, for this question, the HLA-B27, this is the most appropriate answer for making a diagnosis. So, coming to the third question, patient with polyarthritis has the involvement of proximal interphalangeal, distal interphalangeal and first carpometacarpal joint, but wrist joint and metacarpophalangeal joints are spared. The most likely cause of polyarthritis is. So, coming to the polyarthritis, let us see the options here. So, the first is the psoriatic arthritis. So, in this case, the psoriatic arthritis, usually they involve the DIP joints. In case of rheumatoid arthritis, it is usually the PIP and the MCP joints, and also the wrist joint is involved in case of rheumatoid arthritis. In case of osteoarthritis, the most commonly involved joint is the DIP and the carpometacarpal joint of the first ray or the thumb. And SLE, it is usually multiple joints involvement. All the joints are involved. Along with that, there are many soft tissue complications, and they also have nodules. So, and usually the SLE, it doesn't involve the first carpometacarpal joint. So, the likely answer is osteoarthritis. Coming to the fourth question, most specific marker of rheumatoid arthritis is. So, most specific marker, it is not the most sensitive. So, most sensitive is anything that is sensitive, it easily picks up all the positive cases. Also, all the false positive cases are also picked up by a specific test, but sensitive test. But for a specific test, if the test says or gives a negative value, it gives a negative result, so it is very sure that these tests are negative. So, coming to the question, the most specific marker of rheumatoid arthritis is, so rheumatoid factor, it is the most sensitive test. It is not the most specific test. It is usually sent for all the cases. So, it is the most sensitive test for rheumatoid arthritis. Rheumatoid factor is almost positive in 70 to 80% of cases. Anti-CCP is the most specific marker. So, in case of anti-CCP, it is seen only in cases of rheumatoid arthritis, while a rheumatoid factor is seen in all the seropositive arthritis. It may also be a psoriatic arthritis, SLE. Now, coming to ANA. So, ANA is the most sensitive test for juvenile rheumatoid arthritis. ANA. If the patients have symptoms of juvenile rheumatoid arthritis and ANA is positive, then the diagnosis of juvenile rheumatoid arthritis is made. Then coming to anti-dsDNA. So, if anti-dsDNA and ANA both are positive, the likely diagnosis is SLE, systemic lupus erythematosus. So, coming to the next question, the fifth number question, alleged history of road traffic accident presented to the emergency department with an open fracture of the left lower leg. What are the steps in the management of this case? So, any case of road traffic accident or any accident that has an open fracture, so there are very chances that there are going to be it is going to be contaminated. So, the first step is always remove the contamination as early as possible and let not the microorganisms flare up. So, let us see the options. The first option is suturing the wound. So, probably this option is not the appropriate one. We first need to clean the wound and then only we can suture. Depending on the conditions, again we may suture it or we may not suture it. So suturing is not the appropriate answer. Post reduction and applying cast. So it's an open fracture. So with applying cast, it will be very cumbersome for us to. It will be very cumbersome for us to do for regular dressing. And then coming to open reduction and internal fixation. Even this is not the appropriate answer, because the most important part is removal of all the contaminants. So that can only be done with debridement. So any case of open fracture, the first step is debridement. And after we are sure that all the contaminants have been removed, then we can go for suturing of the wound, reduction, and all other things. So the first option is debridement. So this is the most appropriate answer for this question. So coming to the next question, while managing a case of radial head fracture by open reduction method, we supinate the forearm to protect. So whenever in case of proximal forearm fractures where the radial nerve, where radius fracture is involved. So usually if you see the radius, the posterior interosseous nerve and the posterior interosseous nerve is it after it divides from the radial nerve. So if you see, so as the radial nerve comes out, so after the radial nerve comes out, so this is the superficial radial nerve. Then comes the nerve to ECRB, and then comes the PIN nerve. So this posterior interosseous nerve, it pierces the supinator muscle. So whenever so this is the muscle. So as we supinate this muscle, when the supination is done, this supination muscle is relaxed and the posterior interosseous nerve, it just goes posteriorly and it is away from our surgical field. And coming to the other knobs, the radial nerve, it usually lies, the superficial radial nerve, it usually lies just underneath the brachioradialis. So this nerve is less likely to be damaged. So whenever we supinate our forearm, it is usually to prevent the posterior interosseous nerve. Which of the following is the bone forming tumors? So coming to this options, the multiple myeloma, osteosarcoma, chondrosarcoma, and adamantioma. So one of the most characteristics of these bone forming tumors are that they form bone, the osteoid matter, and after the osteoid matter is formed, finally there are osteoblast formation and then the osteogenic cells. So there are only three bone forming tumors. The three are osteoid osteoma, osteosarcoma, and osteoblastoma. So coming to these options, so multiple myeloma, it usually produces multiple lytic lesions. So this produces lytic lesions. Osteosarcoma, it is a bone forming tumor. So this is the right answer. The previous one is the wrong answer. The osteoid osteoma, osteosarcoma is the right answer. Coming to chondrosarcoma, this chondrosarcoma, they mainly produce the cartilaginous matter. They produce first chondroblast, as the name suggests, the chondro. So they usually form cartilage. So this chondrosarcoma is not the right answer. And adamantioma, most commonly it's in the mandible that is affected. Even they produce lytic lesions. So even this is not the right answer. So osteosarcoma is the right answer for the bone forming tumors. So remember, for bone forming tumors, So the bone forming tumors are only osteoblastoma, and osteosarcoma. Let's come to the next question. The examiner asks the patient to put his hand on the waist and then asks to force his elbow backward against resistance. So the position is like this. It goes like this. Put your hand on the waist and the elbow is forced backward against resistance. So if you come to know the trapezius, let's see the options. The trapezius is, it is usually the shoulder abductor. It arises from the occiput, cervical spine, and is inserted on clavicle, acromion, and the spine of scapula. So trapezius is not the answer. The trapezius is associated with just elevating the shoulder. So coming to serratus anterior, the second option, the serratus anterior, its paralysis usually causes winging of the scapula. So it is usually for protraction of the shoulder. The shoulder is protracted anteriorly. It is the movement caused by serratus anterior. So even the serratus anterior is not the right answer. Coming to latissimus dorsi, it arises from the iliac crest. It arises from the iliac crest and is inserted in between the bicipital groove, right up here. So it is usually the posterior extensor of the shoulder joint. So when we do it under resistance, we are activating the latissimus dorsi. So latissimus dorsi is the right answer. Now coming to the rhomboidus, it usually arises just between the spine and the middle margin of the scapula, and it is usually for retraction of your scapula. So even this is not the right answer. So coming to next question. Middle-aged man is under corticosteroid for the last 5 years. Now he complains of pain in the hip over the previous 3 months. What is the most probable cause? So a middle-aged man, so it means usually in the 30 to 40 years or 50 years. So what happens in 30 to 40 years? If you see the peak bone mass of a man, so there is usually bone formation till 32 to 33 years of age. So peak bone mass, it forms usually up to 32 years of age, and after that usually the bone mass gradually decreases. Okay, so now one thing in the question is that he has pain in the hip joint. So pain in the hip joint for past 3 months. So coming to this question, let us see the options. So avascular necrosis. So I think this is the right answer, because if you see that avascular necrosis, it usually affects the hip joint, the scaphoid, lunate, capitulum. So these are the most commonly involved joints by avascular necrosis. So one thing is he has pain in the hip joint, he is under corticosteroid. These are the two factors provoking suggestive of avascular necrosis. Okay, so if the patient is just having avascular necrosis of the hip joint is the most appropriate answer. So let us come, why not the osteoporosis? So coming to why not the osteoporosis, patient is on steroid. This is a factor favoring osteoporosis, but osteoporosis, it usually involves all the bones, mainly the distal radius, the spine, the proximal femur. So the whole of the skeletal is involved. But in this question, there is pain in the hip joint. So this is not the right answer. Coming to osteoarthritis, usually the weight bearing joints are involved, and in case of osteoarthritis, usually the pain further improves, like there are less symptoms on osteoarthritis. So this is not the right answer. In case of rheumatoid arthritis, as you know, there is further improvement in the symptoms. The symptoms decreases, and rheumatoid arthritis, it usually involves the smaller joints. So this is not the right answer. So coming to the next question, patient had a fracture of the middle epicondyle of the humerus. What is in due to injury to the adjacent nerve? So the middle epicondyle is fractured. So the only nerve passing just behind the middle epicondyle is the ulnar nerve. So we shall first examine the ulnar nerve and what are the symptoms that occurs because of the ulnar nerve injury. So let us see. The first question is radial deviation of the option is radial deviation of the wrist. So if you see the radial deviation of the wrist, so I can show you just this. So if you see my left hand, so okay, the radial deviation is like this. This is the neutral wrist movement. This is the radial deviation. So it is usually seen in case of posterior interosseous nerve. So radial deviation is usually seen uh, because of palsy of the ECRB muscle, and ECR is having a normal tone and movement. So radial deviation is seen in case of PI and palsy. Loss of sensation on the thinner aspect of the hand. So if you see the second options, so this is the thinner part, this is the hypothinner part. So this thinner is supplied by the median nerve. Okay. So loss of sensation is because of thinner aspect of the hand. So this is not again the right answer. Coming to the third option, the thinner atrophy. So if you see this, the thinner muscles. So the thinner muscles are mainly the abductor pollicis brevis, flexor pollicis brevis, and optic pollicis. So among these three muscles, so flexor pollicis brevis, it has two heads. One of the nerve, one of the branch of ulnar nerve, it supplies the flexor digitorum brevis, flexor pollicis brevis. So this can be an option. So let us see this, and then comes to the atrophy of the muscles on the first web space. So if you see this is the first web space, the dorsal interossi, it is most prominent over here, and also the flexor pollicis brevis. All these forms the first web space. So if there is ulnar nerve injury, this is going to be atrophied. So the atrophy of the muscles of the first web space is the most appropriate answer. So thinner atrophy is much marked in case of median nerve and atrophy of the muscle, namely the first dorsal interosseous. So because of the atrophy of two muscles, the which usually happens because of ulnar nerve injury, so these there will be atrophy of the muscles of the first web space. So thank you. So very soon we will be discussing about other question papers too. Thank you.